I suspect there's going to be a few stragglers today because of the weather. This has become somewhat of a tradition for the Transplant Center, usually about once a year. Jennifer Milton, our administrator, nationally renowned transplant administrator, sought-out consultant for transplant administration, gives us an update, usually on Medicare, CMS, SRTR, and that's what she's going to do for us today. So, without further ado.
I figured there'd be some stragglers because of the topic, not necessarily because of the. Greg asked me to give a talk, and I chose to talk a little refresher, if you will, on our readiness for Medicare to come in, Medicare to evaluate our compliance with the Medicare conditions of participation. I appreciate hearing it's become a tradition, but it feels very different for me because I'm not dealing with the nonverbals of Dan Riley as I talk about federal regulations. It's so relieving, but Dr. Spade did show up. So I'm going to go over the conditions of participation. They really haven't changed, and they were published in 2007. They became effective in 2008. They've really not substantially changed, although some interpretations of them have. An element has been added called FQAPI, Focus Quality Assessment Performance Improvement. Talk a little bit about why, but that I'm going to focus on a little today. I'm going to touch base on our own opportunities and areas that I expect we may get citations or deficiencies, and then focus sort of on what everybody in the room, if your signature is ever in a transplant patient's chart, just by a tracer, you could be pulled into a room alone with a federal auditor. And they'll say, if you're a medical student, if you're a resident, if you're attending, if you're a nurse coordinator, dietitian, on and on and on, they'll say, how are you trained to take care of this patient? Who informed you about the uniqueness of transplantation? And no one else is in the room with you, and you have to give the answer. No pressure on time. So I thought I would give you a little quick nutshell of an example of the government's forcing us on process improvement. This talk is not about the Joint Commission, and the hospital is due for a Joint Commission inspection in the VA. I'm going to give you an example of process improvement. This was way back, another tradition of the Transplant Center, way back in 2008, and a group of my friends came in and did a mock Joint Commission audit for April Fool's. The clinic was my victim. They formed an April Fool's Process Improvement Committee, and the following year, 90 boxes of saran wrap later, everything in my office, I to this day still find some saran wrap. The next year, they deconstructed my office. They deconstructed my office and reconstructed it down to photographs of my family in cardboard. The next year, this year, I would say we had an adverse event, and we had about 20 boxes of silly string in my office. So this was our April Fool's process improvement, and I hired an actress to come in and get interviewed. And that was a really fun time as well. So that's what happens when you teach me process improvement the federal way. So overall, the regulations cover two broad things: the design of programs and how they're managed, and one-year patient survival and outcomes. And I'll go in depth in these, but how we verify ABOs, how we do multidisciplinary care, and for living donors and recipients, our informed consent selection, and what we submit to UNOS. Those are kind of program design and management. For outcomes, it's one-year survival, that our observed patient survival is above or expected by certain metrics and thresholds. And then the FQAPI was designed. Now, a lot of people get very frustrated in living in the environment of federal regulations. It's over-prescriptive. It's referred to as regulatory purgatory. There's duplicative regulations. And I like to, and sort of say why. Why are we doing all this? This is ridiculous. It's changed the shape of medicine. And so how many of you had one of these when you were a kid, or maybe you drove your kids around in one? So my father prided himself on the fun things we did in the station wagon, and we were never in seat belts. So we had a bucket seat in the back. He flipped it down. He hit the brakes, and we flew up to the front. We peeled off, and we flew off to the back, right? It was so much fun, right? Was it safe? Right? No, it wasn't safe. This is Thomas Hamilton's, who's the head of Medicare Survey and Certification, station wagon picture. And what he shows in this picture is 3 different kidney transplant programs all aggregated. And the yellow line at the bottom are programs for whom their outcomes dropped so low, they got mitigating factors, which is they basically got cited for conditional level deficiency. They appealed to be able to do Medicare transplants, and they were awarded, went into a systems improvement agreement, which is a contract with the federal government forcing you to improve. And you can see that their outcomes, all 4 programs together, are the yellow line. They've done nothing but improved and are the best in the country now. In the red line in the middle, those are programs who got mitigating factors and did not go into an SIA. And there were 11 of those programs. And then the rest of us are in this sort of blue line. So Thomas Hamilton's station wagon, and this is a presentation he just gave, or he just prepared, it wasn't able to give, is that this is working, right? An additional station wagon for him, it's safer now, it might not be as fun, is that the outcomes since the regulations went into effect and were put and monitored in 2008 is that in every type of transplant, survival is astronomically improving. He doesn't give credit to new immunosuppression, new training, new techniques. Nothing else really happened in CMS's eyes to change the landscape of transplantation, except we were forced to get better and monitor ourselves. So I don't see a future where regulations are decreasing. I only see that they're going to continue to increase. And I think that's what got us for this quality assessment process improvement. So I'm going to go over the Medicare regulations first, the ones that haven't changed. These are pretty redundant from previous talks. If you're an existing, already approved transplant center, there are requirements that you submit forms of all your patients who've been transplanted. It's called data submission. There's specific value, percentage you have to be in compliance. The outcomes requirements I talked about, patient survival, 1-year patient survival. And you have to do in all of our approved programs, except for pancreas, at least 10 transplants a year. Several of the heart programs in our donor service area struggle to meet this requirement, and several of our lung programs do as well, to do 10 a year. And there's no requirement for pancreas and intestinal transplant. If you're a brand new transplant center and you're just applying for Medicare because you're insane, then you have to meet all of those requirements. You have to do 10 lungs, 10 kidney, 10 hearts before you even apply, except for kidney, and you only have to do 3 before you can apply for Medicare certification. For the standards, I call these the symbols. You have to notify Medicare of any significant changes in your program. If any of our primary surgeon in the kidney program, if he decided to leave, we'd have to notify Medicare that was a significant change in our transplant program. If our volume in pediatric kidney transplant were to be greater than 50% of our total kidney volume, we'd have to have standalone approval. But as it stands, Dr. Stevens and Greg are the medical and surgical directors of the pediatric program, even though we understand that Dr. Aurora is. The liver program as well doesn't have separate approval. Dr. Spade is the medical director of the pediatric program, and Dr. Washburn, the surgical director, although that's been delegated to Dr. Aurora and Dr. Natal as well. We have to have a written agreement with TOSA to always provide organs for transplant to our transplant center and give us accurate information, and we have to comply with all of UNIS's regulations.
Medicare gets very prescriptive, unlike other regulators, and they give us very detailed expectations on how we care for patients. I'm trying to add in pink areas where we have some opportunities. Okay, so Medicare tells us that we're allowed to decide who can get a transplant and who can't have a transplant. Those are your written selection criteria. So a lot of people in the public will be concerned about sobriety, for instance, as a criteria, smoking as a criteria, obesity as a criteria. Well, what Medicare says, you're allowed to set your own criteria, but you're required by law to comply with it. So in selection, you must have a social worker evaluate the patient before being placed on the waiting list. And if they have follow-up recommendations, those must be done. I put that in pink. We audit it regularly to see not only did we have the psychosocial, the social worker's evaluation, but did we document that we followed up on their recommendations. That can be a tripping point for us because sometimes we recommend that our candidates go see psychology or psychiatry, and then we're waiting and gathering those recommendations, and we don't necessarily always implement those recommendations before a patient gets a transplant. That could be a problem for us, right? We have to have the blood type in the record. We have to document the selection criteria that we used in order to list a patient. If a federal auditor pulled 3 liver transplant coordinators into a room and looked at each one of them and said, tell me your policy on substance abuse and abstinence. Are you confident that the liver coordinator will give the exact same answer? That's a problem for us because it's an evolving policy, and we vary based on the individual patient, which we're allowed to do. So if we have a written criteria that requires a period of abstinence, if the acuity isn't prohibitive to it, then we can document that this patient is an acceptable candidate because strong support system initiated substance abuse counseling has benefits in a provider for post-transplant care. So that's an example of being compliant to our policy and allowing variances based on individual patients. Have we transplanted any livers with a BMI over 40? You betcha. On paper, we weren't allowed to do that, but you want to see in that patient's chart that we selected that patient based on an individual patient and you know what made that transplantable patient based on our policies. For living donor, very similar requirements, and we have no real compliance issue there. I put down in the bottom here on this record maintenance, we're just completing an audit for UNOS, and we're having a massive problem. All of the stuff that you have to do, if it's not documented in the patient's medical record, you did not do it. And so we just audited 10 donor records, and we can't locate part of our records in OnBase, or we can locate partial records. And we've had 2 previous regulatory audits where we were cited specifically for inability to retrieve records and knowing that they were there. So medical records saving, and I know how much all of you love OnBase anyway, and I'll talk about some of our solutions later, but those are written selection criteria policies. Certainly many, many exhaustive requirements regarding how we recover donated organs and what we do when we transplant them to make sure we are transplanting and recovering them for the intended recipient and compatibility is established. You have to verify the ABO 2 different times. One is prior to incision at transplant, they call that receipt. So the receipt of the organ before you do an incision to transplant somebody, you need to verify that the cross-match was appropriate, was adequate and okay, that the ABO is okay, and that the UNOS ID number on the box matches the UNOS ID number of the patient who's about to get the transplant. In one transplant center, several kidneys arrived and they had all ABO and different UNOS IDs, and they grabbed a box with the blood type O, went into the OR, transplanted the patient. It was a high PRA, and they figured it out when the patient lost his kidney transplant, right? So then we got federally mandated to verify UNOS ID number prior to implementation. I will point out that we are no longer required in the surgeon's aid room here, because we still do it at our program, but we are no longer federally required at the site of the deceased donor OR to verify the intended recipient's ABO with the donor at the site. You guys have a form that you sign, and that's no longer a federal mandate that we do that. So I'll say in our, and the other site that we are required is in the living donor. We have to do that twice. We have to do it before we do the incision, recover the living donor kidney. Does the cross match okay? Will the ABO is okay? And do the UNOS ID numbers match? You say, well, that's stupid. You know, the son wants to give to the dad, but with paired exchange and you're having 4 ORs, it's very complicated to make sure the right kidney gets in the right room. So UNOS ID is also mandated there. And then again, prior to putting that kidney in the recipient, you have to do another timeout. So our compliance with this is not a problem, but UNOS has certain requirements, Medicare has certain requirements. The problem, and the problem across the country, is it is so cumbersome to document this. They want so many elements. What time did the organ get in the room? Did you verify it with a visual verification? Did you know, who signed it separately? That transplant centers are getting tripped up just on the documentation. But without fail, at our transplant center, we do a timeout and we verify compatibility beforehand. Nonetheless, we almost always get dinged on it, and almost always it's a simple little additional piece of documentation that that particular auditor wanted to see. So the next area are how we manage our patients, and Medicare has very prescriptive language for this. We have to have a written policy, and then they verify that we practice against our policy. And we have to maintain up-to-date patient records. I put accurate patient records in P because we have that medical record standing problem and often can't retrieve the records that we need to find. Waitlist management is mandated. When our kidney transplant program doubled the size of the waiting list from 2012 to now, we had a massive problem with how we manage patients on the waiting list that we now have a good pool on. We're at risk because the high volume of our status 7s on the waiting list is indicative to the federal government that we do not have a good waitlist management program, right? We have a good policy, not necessarily a good program. And if the auditor bought 5 or 4 years in the room and asked each one of them specifically how they kept their patients up to date on the waiting list, you have to wonder whether we get 5 different answers. When what they want to see is a read your policy, bring 5 people in the room, bring the medical director in the room, Dr. Say, how do you manage patients on the waiting list? Does your policy say we bring them in to get their annual cancer screenings up to date, right? That they want to see compliance with policy. They don't concern themselves too much with the fact you're saving lives and doing disease management. They're just concerned with your adherence to your policy. Of course, keeping notifications in the record as you change patients' active and inactive status on the waiting list, and that the multidisciplinary team is evident, that communication, partnering together with care is evident in the medical record. And you guys are fortunate that your inpatient team documents those notes daily, showing that you came together and collaborated over your patients. They do it for the lung team and the abdominal team as well. This last line here is a particular concern of mine, and I fully expect a deficiency here. In our transplant program, we had about 15,000 visits to the transplant center last year, patients in all phases of care, and that in the adult program, and that was managed by one dietitian. Yeah. And our pharmacy services are particularly, you are mandated in a multidisciplinary fashion to have pharmacy, dietary, and social work available and participating in quality care, discharge planning, in all phases of care. And we know that we don't have enough pharmacy bandwidth. We're just waiting for, we've done a lot to share that information, but we know that we stretch our pharmacists and our multidisciplinary care providers pretty thin. And we try to work on, but you should see at every selection committee you are at, you should look around the room and there should be a pharmacist in the room. There should be a social worker in the room, and there should be a dietitian in the room. And I don't think that you're seeing that. And same with the quality unit, and same with these one-year reviews that we're doing, the high-risk MELD reviews that we're doing. Now you do see them inpatient and multidisciplinary rounds, but it's not all phases of care as we're mandated. Donor informed consent and recipient informed consent, it's elaborate, very prescriptive, what you must tell a donor when they're first embarking upon thinking about donation. And the same with the recipient. We really do an excellent job in hitting all of those prescriptive elements and not overwhelming donors, and they actually do want to donate and they do it all. But we have a problem with medical records retention. In our recent audit, we had an informed consent document. And our informed consent document to comply with these regulations is 6 pages long, 4, maybe 5 or 6 pages long, and like an 11 font. It is like buying a house contract, right? And we found in medical records page 1 and 6. Right? So those are the kind of issues we're having. So also for, and I will just say, let me take a step back and say, nothing I'm talking about today is a UNOS rule. These are just Medicare rules. UNOS rules also hit all of these elements, but they're slightly different, right? So UNOS has very extensive requirements for living donation, medical evaluation, psychosocial evaluation, informed consent elements, and the role of independent donor advocate. And that was a whole lecture last year, and I know y'all remember all of that. Recipient informed consent, very similar elements. You have to tell them all the bad news up front. You have to, and interesting and a problem for us is that all of this is mandated. This is the evaluation, this is the surgery, these are the risks. This is the risk of disease transmission. These are our SRT, our outcomes, and how well we're performing as a transplant center. Before you ever start the evaluation, you need to tell them all these things. And then again, just prior to surgery, you have to get more specific. So one of the issues we have in the program is this donor risk factors. So you tell them at evaluation, and so I'm glad Dr. Scott Johnson is not here because we will argue and argue for, we've argued since 2008 on this. But the requirement is that at the outset of their evaluation, you tell them everything that will go wrong with the donor organ. You could get a malignancy, you could get TB, you could get HIV, you could get, right, general risk factors. And then just prior to surgery, you have to tell them the specific risk of the organ. So if that organ was at risk because the person had high-risk behaviors, that has to be documented on the consent. Specific risk. You don't have to say your donor used drugs by IV and therefore the high risk. In fact, you're prohibited from saying that. You have to say that your donor met the criteria that they are a PHS high-risk donor. The risks are the same as in any transplant, but a little higher. Okay. And we do all the testing, blah, blah, blah. So that should have been pink because we have opportunity there. That I think when our coordinator calls the patient, we have a very detailed script that was designed by our medical and surgical leadership. What do you want us to say to the potential recipient? If it's a split liver, if it's a deceased circulatory donor, if it's a PHS high risk, the nurses have a very prescriptive script that they tell the recipient and document the chart. Then they call whoever's signing the consent form. And it's kind of like that game your kids used to play with a grapevine. You don't quite know what was heard on the other line. So you'll say it was a deceased circulatory donor, and we've seen documented in the chart that it was a circulatory donor, or a directed donation, or sometimes the words don't match. So that informed consent just prior to transplant is a big tripping point for us. And I'll talk again a little bit about solutions and what we're working on there. So all in pink is the new federal quality assessment performance improvement regulations. When I went back to the station wagon and Thomas Hamilton's safety lecture, of all of those programs in the country that got put into systems improvement agreements had drops in their outcomes or grave compliance issues. What CMS feels they have uncovered is the single biggest weakness is their compliance with quality. Because the common denominator in all of these transplant programs was very poor quality. So, like a good regulator, they decided to prescribe it, be more prescriptive with it, and force us to comply. audit processes, our routine survey, which is all that I just talked to you about, right? The routine survey we're overdue for right now. Based on the size of our program, we expect 5 to 7 auditors, and that they'll be here for 5 days. Typically, they'll assign an auditor per program. Well, one for kidney, one for the liver donor program, one for liver, and one for quality. That's one audit. We call it the routine survey, and I expect it on a Monday, given the size of our program, and expect it literally every Monday. We expect it to come. Right? That's how overdue we are. They're every 3 to 5 years, and we're at year 4 now. The FQAPI survey is directed largely at programs who are having survival issues. So if your observed to expected survival drops in one report, it's called a standard level deficiency. And it's Medicare's intent to deploy the FQAPI team to your transplant center then, hoping to avoid a second period where the ODE is matched. I've argued this too, it makes no statistical sense to me. There's an 80% overlap. It's almost like once you get the first citation, you're kind of doomed to just keep going. But nonetheless, they're deploying it. FQAPI became effective, and they did surveys in 2013, and they did surveys in 2014 and 2015. In 2014, 80% of the programs they walked into had conditional level deficiency. Conditional level deficiency means these are conditions of participation. If you don't meet the standards at the condition level, you get a letter in 30 days that they're going to terminate your Medicare participation. Some people, I can't do Medicare transplants. Well, interestingly, if you lose Medicare, first requirement of every single private insurance is what? You must be at a Medicare approved facility. So if you actually lose your Medicare certification, your program will have no screeching call. You're done. You're financially done, and therefore you're really, in a sense, pretty done. So FQAPI, 80% of the programs in 2014 were conditional level deficiencies, and so far in 2015, 50% of the conditional level deficiencies.
Those are programs that fell below expected.
Either in one SRTR report or in 2.
So, do we know what the contrary would be, which is programs that didn't fall below that were doing okay? Did they have
What they said is that they haven't done a full FQAPI on those programs. In our routine survey, they send one auditor who does a FQAPI light survey. We're doing a lot. I'll talk about what we're doing to get ready. We're doing a lot to try to be ready for FQAPI. It's just kind of unclear how the scope of what they're going to do when they come in for a regular audit. We're hoping, because all of our programs have such good SRTR reports right now, we're not a target for an FQAPI, true FQAPI. But we know we're overdue for our routine, and I've spoken about this enough nationally. I'm worried they're going to do an FQAPI because they personally are sick of me. So no, we don't know the answer to that, Kim, but I would imagine 80% failure in FQAPI and 50 to 80 it would be the norm in the country. I think the FQAPI survey is so intense. People are really struggling with how to even deploy it. So let me talk about FQAPI a little bit. These are the things when Medicare says you may want to track. Right? That's the word in the federal, you may want to track. That means you better be tracking it, discussing it, and seeing how you're doing on it. Your adherence to your own selection criteria, accuracy, waitlist management, accuracy of your waiting list. Do we match our patients correctly? Erica does an audit internally in the OR to make sure we vet all those verifications before we did transplant, and on and on. I'm going to go into this a little more detail when I go to FQAPI. So Medicare is also very, very prescriptive on who is required to work here. And so I put in pink a suspect. They would mandate your surgeon to be qualified. Because that was in pink as well. If you are named a surgical director or the overarching medical director, you're required for the talent of your nurse coordinators. You're responsible for good dietary social work. You're responsible that they're sitting at those meetings. Ultimately, since Tim walked in, I'll pick on Tim, ultimately Tim is not as responsible as the medical and surgical leaderships that you are in compliance, your staff is qualified, you're working with your managers to address deficiencies. I will just point out again, we have, this is another area where records can be a problem for us, and I think we've really cleaned that up, but having evidence, all of you come to grand rounds all year round, and you're required to have evidence and participate in transplant physical training in an ongoing fashion, whether you're a dietitian, pharmacist, or a transplant surgeon. So when Medicare comes on site, they pull your credentialing files, you're going to want to see evidence of that you were taught and keep fresh on what you're on care of transplantations. So then there's further, and these are the furthers. So those are what they require for the medical and surgical directors, but they also require that this multidisciplinary team is there. The clinical transplant coordinators are qualified, is all they really say. It doesn't necessarily mean certification, but rigorous training has to be evident and ongoing training. The independent donor advocate, which I'll talk about in a minute, and it must be evident to Medicare that your facility has adequate resource commitment. Infectious disease, psychiatry, and radiology, blood banking, HLA, on and on. Angelina Edwards gave a presentation and she questioned another transplant program that did not have plasmapheresis and said, how can the government let this happen? You're not even able to care for the patients and transplanting high-risk hematological patients. But those are the types of resource commitments that you have to have. The independent donor advocate, notice nothing is in pink, although we're not real happy with our current system, but our hospital's director of ethics serves as our independent donor advocate. And the independent donor advocate only has 3 jobs. It's to make sure that donors aren't being coerced, they understand they're making an informed decision, and that they're basically promoting their interest in acting as an advocate. This is the only team member required to be independent, although we get that jumbled up sometimes. Sometimes the social worker doesn't want to be the same social worker that cares for the recipient, or the doctor feels a little more comfortable if it's another doctor that evaluates the donor. Those aren't federal mandates, but it can certainly be program practice. And we don't fall into this category, but if you're a transplant program that has only a single physician, the patients have to be notified that before you ever put them on the waiting list. Like, hey, we only have one surgeon. If he throws his back out, you're not going to get any organ offers, right? Or if he goes on vacation, you're not going to get any organ offers. It's been an issue for programs in Hawaii and South Dakota, the 2 that have come up kind of frequently, where there's not a real backup, patients have no other access, and there are just periods in the year that patients have no kidneys or transplanted at the transplant center. If for kidney transplant programs, you have to have policies and evidence, and you have ongoing dialogue with the dialysis unit. We are a few hundred dictations behind in getting that communication out, and that will be looked at to say how are we doing. And we have to cooperate also with another regulator, which is the End-Stage Renal Disease Network for a kidney transplant program. So now I'm going to talk about FQAPI. That was just the Medicare regulations, right? Now we're going to go just a little bit to FQAPI, and I'll just give a high-level overview. This is FQAPI, how you design and what the scope of your quality program is. What is your feedback mechanism? What are your quality improvement and process improvement systems? How are your adverse events tracked and reported, investigated? What are your quality indicators? A lot of people call those dashboards. And do you know areas in which you are prone to problems and high-risk areas? And then all of that data that you're supposed to be collecting, are you using it to make yourself better? And how engaged is your governing body and your leadership in transplant quality? Because anytime Thomas Hamilton speaks, he'll say over and over and over, transplant programs function in a silo from their hospitals. And he feels those 4 centers, the yellow line that went all the way up, he attributes that to one thing. We came in, when an SIA happened, the hospital leadership and transplant leadership, hospital quality and transplant quality, met each other for the first time in a room to talk about the oversight and quality. That same thing CMS CMS attributes to improvements in the programs. They finally got together, they finally worked together. So the elements of copy all center on these two sides. What is QA and what is process improvement or quality improvement? QA is, are we auditing, monitoring, collecting, looking at data? We have outcomes charts, outcomes information we do after every transplant. What was the length of stay, length of time in the OR, length of time in the ICU, what was the mean date to extubation? Did it take us greater than 4 days to start nutrition on the patient? On and on and on. Those are QA. After every transplant, we pull those data on peds and adults, right? We also do a regulatory audit. Beautiful. Every time a patient's listed here, another nurse takes a chart and they check, will we comply? Did we list them accurately? Did we notify them of in 10 days as required? We do that just real time, every patient, every time, right? If that's all we did, incredible. I think we do one of the best jobs on real-time audits to make sure we're compliant and we hardwire that. We don't have a quality nurse just pulling charts every 4 months randomly. We do it every patient every time. The problem with us is that we do that part really well. What we really failed to do is the process improvement part. Right? And I gave an example in a living donor meeting the other day that anecdotally talked about some donors that are having mental health issues after donation. Probably no number that rises to a level of significance, but obviously causes a lot of concern for us, right? So we know we're having an issue. We've got the data on it, but we haven't sat down and done a process improvement to really analyze it and say, could we use this information to get better and put something in place maybe so that other donors lessons learned on future donors. So we, I think, are very good at the QA, and process improvement is where we really need to focus. So when you're sitting in quality meetings and you're looking at a high readmission rate, it's not enough that you just look at a high readmission rate. Why do we have it? Are we doing anything about it? On and on. And that's at the high level. So methodically collected data that's used well. This is an actual surveyor's workbook, and they call these indicators. So let's just use length of stay as an indicator. Describe what the indicator is based on. Is the scope of the indicator specific to transplants? Is it appropriately being collected? Are we collecting the right information? Is there evidence of incomplete collection on length of stay? How do we ensure that our data reliability is the same? We measure length of stay from the night the patient gets, the day the patient gets admitted, or anastomosis time. And are people reporting different things, so we're not even looking at the same numbers? These are all, Medicare will come in, pull one element, length of stay, sit down with our new quality nurses, Tricia, one of the managers, and ask them all those questions. Who entered your outcomes? Do you know absolutely that they collect length of stay from admission or from anastomosis? What are you benchmarking yourself against? Are you benchmarking yourself against a national length of stay, Milton length of stay, 10% less than the prior year? Why did you choose those metrics? On and on. And we have dashboards with 30 or 40 elements, so they can trace and look through any one of those. And guess what they're going to ask the surgical director in the medical? What's your length of stay? What do you benchmark your length of stay against? What were your variances for your length of stay? What did you do about your variances for your length of stay? All right, so of course quality has to be broad. They mandate processes in the pre-transplant phase, inpatient transplant phase, and post-transplant phase, and systems. You have to have a minimum of 3 in each. And for each of our 7 programs, we have to have these defined. They define participation. I said again, look around the quality meeting. Do you see dietary? No. Do you see pharmacy? Probably not see pharmacy. You see nurse coordinators, medical directors, surgical directors. They want to see that we're interfacing with bedside nursing. And issue specific, if we're having issues with our cardiology examinations, if we're not doing things, they want to see that those specific consultants and hospital resources are participating in either work groups or live meetings for that. We have to monitor our external contracts. We have to monitor our own data, adverse events, and 10,000 other things. This is just, again, a sample page from the surveyor's workbook. Look right here, this multidisciplinary team. They pull a set of minutes, they pull a year of minutes, and they look at attendees and they start checking. right? So they define participation as routine participation. So people will say, well, does that mean I have to attend 80% of the time, right? No, they'll look, did a surgeon attend routinely, right? And if they pull 12 minutes once a month, and the surgeon was there once, was that routine participation? No. If a surgeon was there 10 of the 12 times, or 11 of the 12, yeah. If they pull it and pharmacy was there once, it's a conditional level of efficiency because the transplant quality committee doesn't have multidisciplinary team participation. So I talked about you must use the data to improve. Right from the surveyor's workbook, it tells you pick a data element. And can the program provide evidence that conducts transplant-specific performance improvements? What documents did you review? Who did you interview? What was their title? So they'll tell anyone, Dr. Spade, show me an example where you took data for an adverse event and you made yourself better. And that's what they want to hear, that you can relate to that. And I will say in our transplant center, and I'm going to pick on Becky and Shanaz. You guys can raise your hands. We're so excited. We're just blessed that the hospital, we partnered, we talked, we knew that we had some deficiencies in quality, and allowed us to bring in 2 dedicated transplant quality nurses. I don't know if there's a transplant center in the country that doesn't have a team of 2 or 3. Their transplant, University of Michigan has 7 employees in transplant quality. So I think we look good on paper, right? And I think our weaknesses are, this is a snapshot of what every program has a quality plan. We took the surveyor's workbook and we walked ourselves through. These are 3 outcome processes we measure in all different phases. These are 3 outcomes that we measure. Here's our collection method. Here's how we do analysis. We then documented all the members' composition role of our quality meetings and what we did. And we have these standard meeting minutes. Again, it's just that I don't think we can show that we're using that data to come back. So I think it looks good on paper. We might do okay in a routine audit, and hopefully we'll have a couple more months to get that circular process improvement part in place as well. So one of the last requirements of FPOPI is there must be evidence of bi-directional communication. We have 6 formal process improvements: lung, liver, kidney, pediatric abdominal, the clinical process improvement team, which is an inpatient team, and a financial process improvement, the only one in the country. We have a formal process improvement for our financial systems, right? Those 6 process improvement meetings report to CMT, care management team, and that is a meeting of inpatient and outpatient quality. It's chaired by Dr. Spade and Dr. Howe. They oversee it. Michael Payne and I and a lot of other team members participate. And I'll show you in a minute, but we report what needs to be reported from the 6 PIs to CMT. And then Dr. Howe represents us on a committee called QRM. And that's a hospital overarching. They don't just bring CMT, which is inpatient, outpatient transplant together. They bring transplant and ortho and EC and the OR all together and report even to that next level, what's going on hospital-wide from a quality standpoint. Medicare won't let you stop there. Medicare mandates transplant quality is reported at the level of the board. So I said bi-directional, so that kind of explains how it all goes that way, or in theory it should go that way. But they mandate it's bi-directional. What's happening at the board should go back to QRM. QRM should be digesting what's happening and take it back to the CMTs all over across the hospital. And then CMT should be coming back to our 6 PIs for pertinent things in both directions that need to be reported. The hospital's gone to a whole new quality system called MIDAS. That happened at the board level, and it needs to be reported down to the process improvement level, that they all know systematic hospital-wide changes in that. If the hospital had increased aspergillus due to construction and all their 3 or 4 immunocompromised clinics, those are the kinds of things that should come back to transplant, so we're cognizant and not encountering our own episodes. Make sense? Bi-directional communication. So again, another area I think we look good on paper. We have standardized our minutes for those 6 quality meetings. If you pull a process improvement meeting, pediatric abdominal meeting, a lung adult meeting, you're going to see a set of minutes that looks something like this, right? So we try to standardize. One of those elements is that if you have an adverse event, you are mandated to use it to get better, right? So quality and risk said you can't call it root cause analysis in quality units. So we called it a reviewable event. And if you have a reviewable event, we even have a defined reviewable event for financial. A patient that called in for transplant, when they got there, their insurance was different. That's an adverse financial event, right? And you certainly know all the clinical adverse events in place in your minutes to put recommendations in standing from adverse events. We have a place in our minutes that is supposed to be a report from CMT and QRM. So it's prompting the people running the meetings to say, hey, what else are they talking about, right? And then we have over here a checkbox. If you're going through something and you need to report it to CMT, or what I call horizontal communication, there's a checkbox. For instance, when we had a TB transmission, that we didn't have a TB transmission. We had a suspected donor-derived TB, or perhaps it was latent. The liver team investigated that. They got help in designing a new screening form for latent TB. One of the most wonderful things that they did is they reported it to all the other programs. So it happened in liver, kidney adopted the tool, and donor adopted the tool. One stopped the lessons and we should have 6 years ago for this. But that's horizontal communication to say, are we using not functioning in silos, these 6 quality meetings. So here's what we're doing to get ready. We designed in 2008, and we're always making it better, something called fire drill. What do we do the first minute Medicare arrives? What's my role? What's Dr. House role? What's Trisha's role? What's the quality nurse's role? What's Camp Maxwell's role? And Mike McCain's role. It's a 10-page document. It's down to who we text, who we call, what the first email looks like when they come in. We keep lists ready. There's an item of 26 things they want. All the patients on your waiting list, all the patients evaluated in decline, all the patients who were removed from your transplants on your waiting list. Every month, Margie updates those, and we have the file ready there. Our policies, we've reviewed them. We're almost there with them completely up to date. The nurses are ready. I told you they do a 2-nurse chart check. I always say to the nurses, when Medicare pulls you around, you got nothing to sweat about. You audit to the Medicare standards every single day you audit another nurse's chart. The nurses are ready for this. The new transplant records, that means that, thank you to Trisha Jones, we now have the new transplant records are Shanaz. And Shanaz has been auditing all of our transplant events prior to discharge and in real time monitoring our compliance. And if she doesn't see a pharmacy note, or she doesn't see a social work note or a dietitian note, she's alerting the team of what they need to do. Every patient, every time, every listed patient's ready to go, every transplant patient we know is ready to go. And for being ready, I said Erica and Trisha aren't quite ready, just meaning it's kind of overwhelming to stay prepared at all times. When they do pull in interviews, I think if you're on there, they'll pull in Mr. Briarty in a room alone, Michelle Ingram in a room alone, our medical directors, our surgical directors. And in the Medicare fire drill, and I will send it out, ask Ronnie to send it out with a listserv, we have a copy of all the questions that they ask. So you have a feel for what what to expect when they pull you alone in a room. And so I think I dropped off one little piece, but let me tell you a couple other things that we've done to get ready. One is we retain Margie Gutierrez every year. Margie Gutierrez is huge and integral to our transplant program. 2 is we are going live with TransChart in January. TransChart is a patient-centered database that pulls data from Sunrise, from Epic, from Quest, and we can customize all the reports that we need. And we have, it's been long overdue, but it automates so much that we have to do to help us be compliant. We hired 2 quality nurses to help us turn the wheel. We knew we were doing quality assessment, but the wheel's got to come all the way back, and we've got to do process improvement. And that's exactly what the ground running, and that's exactly what they've been doing for us. We've performed really well in our UNOS audits. And again, there's an overlap, and we know that that's helping us get ready. We've mock audited ourselves, and we're planning to do an FCLACI mock audit. And medical records, I was giving Tricia credit that she has worked and worked with medical records. Medical records scans thousands of records every day, and transplant might send 250 pages. So what Belmar, head of medical records, is going to do is send a scanner to our department for a few hours every day to get to know transplant. So when she sees something that doesn't make sense, she'll be able to walk into Vanessa Lopez's office or Barney Farnham's office and clarify why things are a little off. And so we're very excited about that. And although transfer will help a little bit with some of that. So anyway, I think it's, I hope today didn't scare you, but got you a little more ready. If Medicare, they could be here Monday, they could be here the following Monday, but just a little bit of an overview of all of it. Oh, here we go, Margie retention plan. 1 year, one other area of compliance, the SRTR. I had my slides out of order, I'm sorry. The SRTR and the observed to expected is really what dictates all of this. And if our O to E begins to fail, so probably one of the most critical things we're doing to be ready for regulators is the 1 year review tracking that the liver and kidney program in Milton has been doing for a long time. Having a handle on all your patients in this first year and knowing how they're doing and communicating. And I think we did that really well with patients until we discharged into the referring doctor in El Paso or later on the island. And so how is your patient doing? Your stable patient in month 7 is just as important to the program as how your patient's doing in month 1. The electronic consents are probably the last thing I'll touch base on. And the electronic consents is a project we took on to eliminate that errors in how we were writing, both the specific risk of the donor and then the detailed risks of the patient's care. So I think those are all the things we're doing to hopefully be ready and perform well and not be one of those centers that gets a conditional level of deficiency. So